Welcome to Conversations in Lung Cancer Research. This is the TOGA podcast, where we usually discuss the latest breakthroughs in lung cancer research and treatment for both Australia and New Zealand. I'm Adnan Nagrial. I'm a medical oncologist. I'm based at Westmead Hospital in Sydney. I would like to acknowledge the traditional custodians of the land on which we are all living and working. We pay our respect to the elders past, present and emerging, and we extend that respect to all Indigenous people potentially listening. So today's episode, we're going to discuss immunotherapy and the recent broad listing of ipilimumab and nivolumab, which was listed on the PBS here in Australia on the 1st of March. We're expecting a listing for pembrolizumab in a similar fashion very soon. And it does allow us to potentially widen our use of those two agents based on clinician discretion and what we perceive as potential benefit of those therapies across the advanced or metastatic cancer landscape. This is going to be the second part of a 2-episode series. So please do listen to the first episode, which gives us a bit of a background on the listing and the rules. But today we're really going to discuss how we could potentially use the evidence we already have for the agents for ipilimumab and nivolumab, and how that potentially will give us more options for our patients across the thoracic malignancy space. In terms of thanking Bristol Myers Squibb for sponsoring this podcast today, and note that the development and editorial decisions of this podcast, though, are made independently by the speakers today. So we're very lucky. We've got 3 fantastic people joining me on the podcast today. So Professor Nick Pavlakis, who doesn't need introduction, former chair of TOGA, senior staff specialist at North Shore Hospital, professor of medicine at University of Sydney. Dr. Sam Bowyer, colleague of mine, a medical oncologist at Charles Gairdner Hospital in Australia, as well as an oncologist at Linear Clinical Research, a phase 1 unit. And joining us from Melbourne, Dr. Lavinia Tan, a medical oncologist based at the Peter MacCallum Cancer Centre. Join me in welcoming them all to TOGA's Conversation in Lung Cancer Research. So we're going to tonight hopefully cover how we could potentially use these new listings to look after our patients across the thoracic cancer landscape. We're going to hopefully cover non-small cell, small cell potentially, mesothelioma, and the rarer indication of thymic malignancies, which really is one of the cancers where this new listing potentially can help us, because it's one of those rarer cancers where the data is more limited. If we've got enough time, we're also going to try to cover toxicity and management of these agents, monitoring of patients on treatment and off treatment, and potentially the survivorship issues that we all will continue to deal with patients who hopefully will do very well with these treatments and live longer. So I might start off by just asking each of my panel members, with this listing, what's your immediate thought in terms of thoracic oncology and our patients in clinic today? How's this helping you already? Have you already started using it? And your first thoughts for that. So I might start with Nick.
Thanks, Adnan. I haven't actually started to use it yet, but I've thought about where I would use it. And the things that come to mind are, relapse after use in early stage disease in curative settings. So that's either in the adjuvant perioperative setting and you have an early relapse, or in the post stage 3 setting where you've had consolidation durvalumab. So that's one setting. The other clinical setting is in the patients who have taken to the 2 years and completed their therapy, and then I get the setting of recurrence or relapse, however forms that take, and we can discuss that through this conversation. I think they're the 2 obvious immediate ones in the non-small cell setting for me, where we have time-limited use through the PBS of our immunotherapy agents, and now we have the flexibility to reintroduce it afterwards.
So Lavinia, I guess in terms of your thoughts, beyond what Nick has already mentioned, what were your immediate first reaction when you heard that these drugs were on the PBS?
Oh, actually very similar to what Nick said. I think, it was a welcome for patients, especially, when it's taken away the once in a lifetime listing on PBS. So definitely, I think in Peter Mac, we have a sort of a guideline on which patients would like to use this for. And so, exactly what Nick said in the non-small cell lung cancer setting, especially I think those patients who did well and stop immunotherapy after 2 years. And some patients actually had quite a long time off immunotherapy, but then somehow relapse. And then so to be able to use that again, I think it's a good thing for our patients for sure. That's for, non-small cell lung cancer.
So we'll take that as a segue, Sam. Might get you to start. So in terms of non-small cell lung cancer, now that you've got access to ipilimumab and nivolumab in that space, where do you think the evidence suggests we should be using it? And where does the evidence lacking and we need to think about how we could potentially use it?
Yeah, I think we need to really go back and scrutinize the data because a lot of these first-line studies were compared against chemo rather than comparing one regimen to another. And lots of these studies now have the longer-term follow-up out to 5 or 6 years, and we see similar outcomes. We know obviously toxicity profile is different, immune-related side effects with combined immune checkpoint inhibitors, but then you do get obviously chemotherapy-related side effects, which, might be something that you factor in your patient selection. I think we have to go back to potentially what biomarkers are going to help us here, and whether we actually know enough about the biomarkers at this time point to even really help us with whether you go for a chemo IO approach or a combined checkpoint inhibitor plus or minus chemotherapy. But there has been some studies that have kind of looked at this and also retrospective data, and it doesn't look like the long-term outcomes necessarily are different between those two regimens, and potentially PD-L1 or TMB isn't really going to help us. And whether it's something more granular like co-mutations, which potentially lots of people don't have access to more broad panel next generation sequencing, but I think there's going to be lots of patient factors that potentially sway you in one direction or the other.
So, Lavinia, I guess with the data we have, so we had Checkmate 227, so in the frontline setting for patients with lung cancers that don't have a driver mutation. We have 227 with Ipi Nivo plus chemo. We've got 9LA, slightly different way of giving it. Is that enough? Who's going to get the dual agent in your practice?
Yeah, so I think with 9LA with the 2 cycles of chemotherapy, there was evidence in patients with low PD-L1 or PD-L1 negative. And also I think they did TMB with the study as well. And I think squamous patients obviously also did better on the 9LA study. So I think when I'm thinking about, I guess you did mention biomarkers. So PD-L1 is sort of the one that is, I guess, the most consistently tested in all our patients, I would say. We don't get TMB for any of our patients unless they get broader testing, as you mentioned. So the way I see it is, we have to look at the PD-L1 high versus PD-L1 low. And then, of course, there's that subgroup in the middle, which is PD-L1 1 to 49%, which is sort of the most contested sort of middle ground. But so with Checkmate 9LA, like I mentioned, I think, the addition of the chemotherapy, just 2 cycles with Ipi Nivo. Yeah, usually it'll be patients who have PD-L1 negative and squam. And the other thing you mentioned about was the co-mutations such as STK11 and KEAP1. So that's probably where I use it.
So Nick, do you have an algorithm in your head now of who you might consider giving Ipi Nivo? Is it the same as what Lavinia's mentioned, those co-mutated patients or PD-L1 low claims?
Oh, good question there, then. And I think just to build on Sam's point about evidence or lack thereof, the evidence we need to make these judgments actually isn't there at the moment. All the first generation studies didn't address the questions that we're trying to answer now in deciding this. So we're extrapolating, applying a bit of intuition, dare I say it, and I think we need to provide more evidence. Perhaps, with one thing to say as a TOGA representative is having access to this therapy now probably gives us the opportunity to perhaps develop a bit more evidence, collecting the data, but we can build on that concept better. So in principle, I tend to think of combination therapy with CTLA-4 in the groups that probably won't respond so well to either standard chemo, single agent, pembrolizumab combination approach, or PD-L1 high, where you think of a single agent approach. So like Lavinia's indicated already, low PD-L1, perhaps in combination with chemotherapy. Then you have patient factors, as Sam says, that whether you think the patient's capable of having chemo combined with the combination immunotherapy. I do like the regimen of low-dose Ipi, as we tend to use in the mesothelioma population, but that actually is reasonably well tolerated. So as opposed to the traditional melanoma protocols that some of us may not be familiar with. So I think it does lend itself more broadly, but I tend to use it in those groups. Do I know which specific patients? Not sure. The concept of the co-mutations, still hasn't been fully developed. And we're talking about really empiric therapy in wild types, because a lot of our patients that we identify through oncogenic testing, including the RAS patients now, go down different pathways. So really we're talking about those patients who are left, who we haven't identified to fit into an oncogene subtype. And even then, the KEAP1 and STK11 story, I think, is still not completely sorted. It's the best we have, but we don't know it completely yet. So I think one thing I'd like to say for us all in the Australian community is, if we can somehow collate some information on our experiences, if we start to broaden it here, we might start to think of whether what we're doing is right or wrong and learn as we go along. I don't think we're going to get very prospective studies randomized that can address these questions for us, because this is an application of proven therapies in practice. So this is your phase 4 or subsequent development of evidence.
So I think the consensus from everyone here is we've talked about how we might use ipilimumab as an option to patients that we would otherwise give chemo and pembro to. What about a chemo-free regimen? Is there any patients out there that you consider giving ipilimumab and nivolumab and without chemotherapy? Do those patients exist? Who are they? And when would you consider it? I'll ask Sam that hard question.
Well, I find it hard to conceive the patient that could tolerate combined immune checkpoint inhibitor toxicity that can't tolerate combined chemo-IO toxicity. So there will be, some factors. Maybe someone's got cytopenias for some reason, but they're of a good performance status where you might be swayed to an IO-only regimen. There might be patient preference that they just want a combined immunotherapy option. Obviously, this is a fairly well known in the community that immunotherapy has revolutionized cancer treatment, and patients come in asking for these things. And I wouldn't think it would be unreasonable to give a Checkmate 227 regimen over a chemo IO if I felt that the patient was suitable. So I don't know if that answers your question, Adnan.
Well, I think in fairness, there is no answer to the question. I guess the challenge is that from a PD-L1 high population where we would consider giving single agent pembrolizumab, we actually do have data showing that adding Ipi to that patient population without the chemo is actually, it was a negative study. So MSD did that study showing that adding Ipi to that population doesn't add a benefit, it adds toxicity. So we've actually got negative data for that. So it's challenging. I think we focus on the frontline patient, but I think, Nick, you brought it up earlier about the patient that potentially has had previous immunotherapy, whether that's in the adjuvant setting or in the frontline setting and completed therapy or stopped therapy after a period of time. Is that the patient that you would consider rechallenging? And if when you do rechallenge, are you going to rechallenge with Ipi Nivo now, or are you going to just rechallenge with single agent PD-1? And how would you make that decision? Obviously, it's theoretical.
Good question. And I think the first thing to say is it's not a homogeneous population, right? We're going to have different cohorts. There'll be the patient who's had exceptional response. Lavinia alluded to that sort of patient earlier with perpetual single agent maintenance therapy, who has a late recurrence and perhaps a small volume disease. Probably would look at single agent in that approach. You tend to think of a patient who's never had a great response, but who has persistent disease. If they'd stable all the way through, you take the brakes off after the 2 years are completed and they have an early relapse. That's the kind of patient that I'd be thinking perhaps more of a combination approach, possibly even reintroducing chemo in the sort of 9LA type concept with it if they've had a long gap from their chemo, because they've got higher burden disease and they're more likely to prone to be resistant. And again, that's just trying to intuitively think of the patient's circumstance. I don't think we can have a one-size-fits-all approach. I think we've got to look at the clinical circumstance, the duration of therapy, the type of response they had, where they are in their journey, and what the pattern of recurrence has been, and then make a judgment. And I tend to, and I guess the common sense approach is more therapy in the worst prognosis situation, single agent approach in the patient who's sent to have done better and has recurred. And that's general principles of how I'd approach it.
So Lavinia, now one of the other benefits with this new listing is that we don't have that once in a lifetime limitation. So that imperative of continuing the treatment for 2 years because you won't get a second chance, that doesn't apply anymore. So are you going to be more inclined to potentially recommend ceasing earlier than 2 years for a patient doing well? Or are you still going to give everybody 2 years? If you're not going to give everybody 2 years, how are you going to make that decision?
Oh, it's a hard call, I guess. Obviously, some patients just don't really want to stop, even if when it comes to 2 years and you tell them, actually, it's 2 years on your immunotherapy, they're like, really? It passed so quickly, still on immunotherapy. So I think that we don't know. We don't really have biomarkers to tell us and to guide us. I guess, people are looking at things like using circulating tumor DNA to see whether or not we can de-escalate therapy. There are patients who potentially are really good responders. There are patients who have complete response and then, a sustained response as well. And potentially those patients have good disease biology and we could stop it. But then once again, is a discussion with patients as to whether or not they want to stop, and some patients just don't want to stop. So, I don't really know the answer, but I think the flexibility is there, as you mentioned.
So Sam, the opposite question, you can continue it forever now. Are we going to be more inclined to continue the treatment beyond 2 years?
I don't think so. Maybe I'm skewed by my N of a handful that have, completed 2 years and lived 5 years on. I don't think we clearly have got evidence that beyond 2 years is helpful. I don't know whether you remember that second-line Nivo study that was a 1 year versus continuous, and 1 year did less well. Obviously, this is a slightly different population. So in my mind, I would continue unless there was toxicity or patient factors that said they wanted to stop before 2 years. I think if patients have had toxicity, I've been more inclined to have to potentially rechallenge those patients because of the once in a lifetime and the 2 year time frame, particularly if patients have not had a lot of immune treatment. So I might refect on whether I would rechallenge someone early or whether I would just wait. And I guess the rechallenge question is tricky because, as Nick said, it's this kind of heterogeneous population, and those patients that have had a long interval off immunotherapy are likely to do well, but those that have had a fairly short interval of immunotherapy are not going to respond as well as they did the first time, and whether we do need to look at potential escalation of therapy for those patients. But I think we also need to be responsible about it, and I think we have got opportunities to collect data, even if it is just observational data about what the practice is, and then we can reflect on what's working, because I don't think we're going to be able to get the randomized control trial that's going to tell us what to do here.
Yeah, Nick, in your practice, do you use any tests or anything that helps decide whether you're good to stop? I mean, the 2 years we're forced to now, but we won't have to. Is there any tests you might do to sort of give comfort?
Yeah, the only test I've done has actually been a PET scan, but I don't know that it's always helpful because sometimes you get a bit of inflammation around the tumor, and it's certainly not as dichotomous as the melanoma guys say, oh, the PET's clear in a year, you can stop. I'm not sure we know that in lung, you're certainly around the lymph node status. Lavinia alluded to obviously ctDNA, but I haven't used it in the wild type immunotherapy population. I've certainly used that in oncogene populations where I certainly had access to some observational studies where I've done it. So I don't quite know, I guess, until I've started to do it. We are going to be embarking on a a ctDNA study on campus, so I might start using it a bit more, but maybe whether it actually is as useful as I think, because, if you don't know what you don't know. I've done circulating tumor DNA. You find some P53 at low VAF levels floating in the background. What does it mean? Can you stop? I don't know. So to answer your question, a little bit of intuition, judgment, but nothing that I can hang my hat on that says I can trust it. So you consider the patient, you consider their symptoms, you consider where they're at, and sometimes it's an emotional decision. They don't want to stop, or they are happy to stop, and we watch them, and we go from there.
I think we all agree that this listing does give us an opportunity to potentially collect some real-world data about what we're doing with patients at that 2-year mark. And we'll do different things. I'm similar to you. I do a PET scan for better or worse at the end as well. And I agree, it's not always helpful. And is MRD at that point really going to be important? You would think so, but again, access is a problem. Might move on to another couple of tumor types, and we can always come back. But so, Nick, you see a lot of patients with mesothelioma. We've already got nivolumab and ipilimumab approved for mesothelioma in Australia prior to this listing. Do you think the access changes anything about the patient population with meso?
Yeah, mesothelioma practice has changed since the approval of Ipi Nivo. A lot of us have tended to use that front, even though the magnitude of benefit was greater in non-epithelioids. There is still a trend, 0.86 hazard ratio in favour of Ipi Nivo in epithelioids, and because of the toxicity profile benefit. And patients often just are more inclined to say, yes, thank you, I'll take combination Ipi Nivo, but you talk to them about chemo, it's not so great. Having said that, there are some people where chemotherapy is still a better choice up front. I tend to find the peritoneal mesothelioma patients, the BAP1 associated mesothelioma patients do better with chemo. In Australia, we don't have access to chemo combination as in the Canadian trial. So a lot of my patients will have had Ipi Nivo up front. I tend to keep it going in a similar vein as we do in lung cancer, complete the 2 years. It's a different disease, and I definitely would like the opportunity to have it to use again. There are some people, as you know, with meso who had high burden disease that hangs around, and you're just holding them together, and you worry when you take the brakes off at the end of 2 years, they're just going to progress quickly. That sort of patient I'll probably keep going with. It stopped at 2 years because that was a study design. And then there are other patients who have had fantastic responses who I would stop, and I've got a few of those who I would definitely rechallenge. But chemo still works in some patients with mesothelioma, and then again, it's not a one-size-fits-all approach.
And I'm not sure, Lavinia, do you see patients with meso in your practice?
Yeah, we do see patients meso.
So I guess my question was going to be that now that the list, I guess the main change in the listing that you can do this now if you wanted to, you combine chemotherapy with ipilimumab and nivolumab, or with nivolumab. It's a pretty general listing. Is there a patient population where you consider giving both upfront, or at relapse, or at any setting? Is that combination something you would consider?
So the combination of Ipi Nivo and chemo.
Chemo and immunotherapy.
Yeah, I think, the meso patients, some of them are probably not as fit. So I guess, have to consider patient factors as well. Some patients come in and their performance status maybe not as good. And so, I definitely discuss chemotherapy still if they're epithelioid, but also discuss, the combination of Ipi Nivo. I've never discussed a combination of both. But, there are patients who are quite gung-ho and do want all treatment together. I did have one patient in clinic the other day who said, why can't I have chemo and Ipi Nivo? But, it was a discussion because I guess she was epithelioid, but she also had other autoimmune conditions, potentially like Crohn's that was not that active, for example. And so, we said, we'll do it with caution with Ipi Nivo. And she was like, well, if Ipi Nivo can cause problems like that, then should I go with chemo? But then she didn't really want chemo. Anyway, it was a discussion, basically. So no, I've never combined them.
So Sam doesn't look after meso, so I'm going to go back to you, Nick. Same question. Pembro's got a positive recommendation for similar listings, so we should have access soon. But regardless, are you going to give chemo immunotherapy to patients with meso, and who?
Yeah, so let's not forget that the median age of mesothelioma patients in Australia is 77. And so we're talking about elderly populations here. So that general population, I tread cautiously and look at factors that, as Lavinia says, is what are they capable of? And at the end, we're really balancing the desire to prolong life, but also to improve quality of life and maintain it. A younger patient, look, we might think differently. I've certainly had a few younger patients with mesothelioma. One that springs to mind was an inherited form of non-asbestos, which is rare, the BAP1 mediated. My limited experience to date suggests that maybe Ipi Nivo is not as good in that population, actually, and that the chemo is important. So that's a group that might want to look at chemo combination with when I get the next opportunity. And I guess some histologies that I've, again, not just treating the patients, but also reviewing them from a medical legal perspective. You see patients' journeys and what they've had. There are some high-grade epithelioids that do very badly. They present late. They have conventional poor prognostic factors such as adverse hematologic parameters, as you know, high NLR, LDH, etc. They do badly. And they do worse sometimes than the sarcomatoids, which do respond to combination Ipi Nivo. So that's a group where I probably think of one chance. If they're well enough, I'll probably look at chemo combination in them. Sarcomatoids, I'd probably be happy to go with or biphasics with Ipi Nivo straight away and see, because they don't do well with chemo. And then the more slower, more indolent epithelioids, happy to try Ipi Nivo on the basis of toxicity preference over chemo. And
so you wouldn't be suggesting the DREAMer protocol or the Canadian protocol of chemo pembro now that you can?
Well, if we get access to pembro, you would. That's what the group I'm saying is I'd probably think of that in the more aggressive epithelioid subtypes who have poor prognostic factors at baseline, lost weight, that they're sliding quickly. You're going to get one shot at those. So probably we'll look at chemo IO combination. Yes, I was thinking of Ipi Nivo in that sense. Would I combine all four? Probably not. I'd probably combine what I can get access to. And if you looked at the Canadian data, the magnitude of benefit isn't as high in terms of the hazard ratio, but the trend's still there in terms of superiority over chemotherapy. But it's trying to find who they are. And I said, my immediate thinking of what my last 10 patients who I've had, who would I've liked to have gone back and done that to? It'd probably be that poor risk epithelioid population who I want to give both therapies, chemo and IO.
I mean, that makes a lot of sense. We might move on to small cell, which might be a quick conversation or a long one. Sam, you can't get out of small cell. You must see lots of those.
No, that's for sure.
Now that we have Ipi Nivo, does it change your practice for either limited stage or extensive stage small cell?
No, it doesn't help us, does it? Ipi Nivo has been extensively studied in this population and not really demonstrated any superior efficacy. We obviously give single agent IO in the first line with essentially limited benefit. The Adriatic data was in the limited stage was more impressive than I would have expected, which is pleasing to see. But I don't think either Ipi plus chemo or Ipi Nivo in this population is really a therapy that I'm going to utilize based on prior data, which is unfortunate for a high TMB tumor. You'd have hoped to have seen great things, but obviously that didn't play out in trials.
I think the trials are pretty uncompelling for Ipi Nivo and small cell. What about continuing immunotherapy in the patient that progresses after first-line therapy, Lavinia? So the patient that's responded to chemo IO, they've done maintenance IO for a little while, and then they start progressing. When you're thinking about switching to either rechallenging with chemo or to switch to an alternative agent, would you continue the immunotherapy or would you always stop it?
Yeah, I guess it's hard to know. I would usually stop it. And when they progress quite quickly, right? So you really want to start the next line of treatment quite quickly as well in small cell. And usually for us, that's sort of, chemotherapy based.
So Nick, is there any role for immunotherapy beyond progression in thoracic cancer?
Well, I was thinking of the question you asked earlier to my colleagues. The occasional patient that behaves differently, and Lavinia's highlighted the normal patient, the rapid progressor, what you don't often get a second chance to. I've had a patient who had 5 lines of therapy with small cell. This is the sort of perpetual clinical trial patient. They had other 2 sites of progression of disease. That sort of patient, I would continue the immunotherapy. If they've had a long period since their last chemo, reintroduce platinum-based chemo again, and you may see a second or period of sensitivity, or you give some radiotherapy to a dominant progressive site and or some disease control. But these are the exceptional patients. They're not the norm. The norm, I think, even is highlighted. And I guess nowadays we're very lucky we do have access to some other therapies coming into play that we may wish to go to, like tarlatamab, and for those of us who are lucky to have some of the trials, the bispecifics coming in, and some ADCs that are looking interesting in small cell. So I guess generally small cell, as you know, if they progress quickly, you don't re-challenge with the same drug. It's a unique population that you get to do that too.
Tend to agree. We're going to move on to a really hard topic because the data is so difficult and so limited. Thymic malignancy, so a rare thoracic cancer, but we do see these patients across the spectrum of thymoma and thymic carcinomas. It's a relatively understudied disease. It's a rare cancer. This listing could potentially benefit patients with that condition. Is there a role for immunotherapy in thymic malignancies? And how would you use it? Might start, Sam?
Yeah, I've debated this one. We collected some retrospective data and published that just in 22 patients with a reasonable objective response rate, chemo IO, but also reasonable objective response rate to chemo alone. And really the duration of response wasn't much different. There's been some prospective data looking at that, single-arm phase 2, which is kind of the study design you expect in a rare patient population. And, I think that didn't really demonstrate a significant improvement in PFS or anything wonderful. It's not recommended through guidelines as a combined first-line approach. And then this leads us into should we be doing things that aren't guideline-driven? Is there enough strength of evidence to utilize that, or should we be saving it as a second-line agent? Technically meets PBS criteria of a potentially immune-sensitive cancer. I mean, it's a second-line agent, but to use it in combination up front, I don't think the evidence is that straightforward to do that.
So, Nick, I guess similar question. Would you use immunotherapy in a patient with a thymoma as opposed to a thymic carcinoma?
Articulated the story very nicely. I have used it. I'll give you some anecdotal experience, more likely in the carcinoma population than the thymoma population. The concern with the thymoma population is adverse immune-related toxicities, and I had a patient who felt strongly that they wanted to do it, and they had a serious adverse event and died. It was a young patient who had exhausted conventional options, so I guess there's a strong argument to try, but once bitten, twice shy. And then the thymoma population, I think, is different to the carcinoma. Sam said, we don't have high-level evidence here. We do it because we want to have an option for our patients. But this is a disease that I think we're never going to get very strong evidence. We have to collate what we do and gather that in the real-world setting and see what outcome we have. I do worry. So I think my lesson would be thymomas, be worried about immune-related toxicities, making things worse. And obviously thyroid cancers, that's a different group, and that'd probably be where the distinction is if you're going to think about it.
So Lavinia, when you started this podcast, you mentioned that at Peter MacCallum, you guys have a list of what they consider immune-sensitive cancers. I guess my practical question is for people that are, trying to implement the use of these therapies in their own centers. How was that list come up with, and what's the threshold of immune sensitive? Is it Nick Pavlakis says it is, or is it phase 3 evidence? I mean, is it somewhere?
Yeah. Well, ours is what Professor Ben Solomon said it is, and we all follow. Pretty much, yeah. I guess, immune sensitive is a broad tip, right? Even things like thymoma can have so-called high PD-L1, and some people would be very, would want to treat patients with a PD-1 inhibitor or immune checkpoint inhibitor, but of course, like Nick said, thymomas are different than the thymic carcinomas because obviously they've got an autoimmune sort of component to it, the paraneoplastic syndromes. And so the addition of the CTLA-4 or even the PD-1 inhibitors will cause very high grade tox for them. Yeah, but that's basically our guideline.
So I think that leads into one of the, what I wanted to talk about to end the podcast was really about the toxicity management of patients on immunotherapy. I mean, these are not new drugs for us. So in itself, we're not reinventing the wheel. But Sam, I guess from a governance perspective in your hospital, Charles Gairdner, that decision of a patient being offered immunotherapy in this new indications where you can give it to anyone, is there any sort of, do you have a similar immune sensitive list that Peter Mac has? And again, is it Sam Bowyer decides who's on it, or is there a different level of governance, and what does it look like?
Yeah, we're still debating this, what it's going to look like, and I've kind of triaged things in my head. Technically we should prescribe within whatever's been TGA approved. And some of my concern about this agnostic listing is, will pharma want to get these additional TGA approvals, or people are just prescribing it anyway? So that kind of check and balance won't exist anymore. I think if you've got something in international guidelines, then you're pretty safe. And then if you're prescribing outside of guidelines, you definitely need peer review and you need some reasonable strength of evidence. I guess for some of the patient cohorts we're talking about, there is that strength of evidence, but these smaller rarer subtypes of thymic cancer, for example, or thymoma, where you're not going to have that, you definitely need a solid peer review. I often say to the trainees, how are you going to stand in the coroner's court to defend it? And I often kind of reflect on that. And I think when you've got potential complex, life-threatening immune toxicities, you need to be very measured in your approach as to how you're going to do that, and make sure that you're making safe decisions. Just because, medical oncologists are like, it's like candy in the candy shop now for us, where we can liberally use it. We just need to make sure that we're being very safe in our approach and having these checks and balances. And it probably does need to be formalized somewhat, but definitely down to a level of peer review if you're kind of going a little bit off-piste.
So, Nick, do you imagine that at North Shore you're now going to have a lot more patients with IO tox because of this listing? Or do you feel like we use the drugs a lot anyway and it's probably going to stay similar?
Yeah, I think we're reasonably familiar with it. It's the toxicity will come, I guess, perhaps choosing the wrong patient. And I guess, bro, I agree with Sam. Had some good comments there about peer review. We do a lot of that. The evidence-free area, we talk amongst ourselves and say, here's the right decision. And I guess you all feel more secure knowing that, rather than making an isolated decision that even where there is absence of evidence, there are some compelling justifications to give something a try. We're familiar with a lot of the strange IO toxicities from our melanoma colleagues up the road coming into the hospital. So I'm not saying that makes us feel more comfortable, but you still got to be cautious. We've had a few strange neurotoxicities recently, patient after first cycle. We've got to remind you that these are potentially toxic drugs. Statistically, the odds aren't high for serious adverse events with single agent, but they are with double. They are higher with double. And we've got to be acknowledging of that.
I guess the other side of that is obviously there's the risk of toxicity potentially increased with the dual agent and potentially using it in a wider population. But the other side of that is we're all hoping we're going to see a lot more long-term survivors with access to a therapy like this. I mean, ultimately, that's what the PBS listing is about. Do we need to do anything differently to be managing patients that are potentially now hopefully going to be living longer? Those patients with thymic carcinoma that you now have access to, the patient that can be rechallenged, if we believe that helps them. We're going to have these patients in survivor follow-up. Do you keep your patient with metastatic lung cancer that responded to Pembro in your clinic forever, Nick? Or do they leave clinic when you retire?
I just see them less often. My first experience with immunotherapy was second-line Nivo. I've still got patients alive on the compassionate program from that. And one particular patient springs to mind because after a long time, let's just say 6 years, we decided, should we stop? And at that stage, partly we didn't because we had that 1 year versus 3 year data that Sam alluded to, stopping after 1 year of Nivo. And so we just, both of us were a bit scared of stopping because we couldn't also get the drug back on again afterwards. So we were frightened of stopping. But now we have flexibility. I'm more inclined to stop in a patient who has established disease control over a long period of time. They're asymptomatic. What's the harm? Stop it and follow them. And if they've relapsed because you've stopped it, then you've got this option now of rechallenging. But I think we're going to learn that there are some people now, and guess perhaps by collecting data prospectively, we can see what the identifying factors are that will go on to long-term survival, that we maybe could have stopped ages earlier, but we were too scared to do so because we were worried we're never going to get the drug back again, and they didn't want to stop because they were too scared to do so. I think we now had that option on a few patients.
So Lavinia, Peter Mac's a busy place.
Yes.
If your lung clinic is now potentially going to look a little bit more like your breast cancer clinics where people are in clinic for decades, or do we need to change how we work?
Well, we just had a discussion today. I mean, there's a clinic for everything in Peter Mac. We've got, survivorship is a big thing. So Michael Jaffe leads the survivorship at Peter Mac. And, today we were talking about an initiative where potentially we could look at this kind of patients who are living a lot longer, and whether or not we could transition them to like more of a survivorship clinic, and whether that could be a shared care between oncology and GP potentially, just like what you said, breast cancer patients potentially could go to their GPs if they're on long-term endocrine therapies. But I'm sure, all of us love our patients, so we might want to keep some patients to ourselves. And then, we are looking at survivorship for these patients.
You need a mix of good patients and bad patients.
And
if you're on a clinic and everyone was sick, and you did that every single day, I tell you, you're going to have a terrible week.
No, I absolutely agree. I mean, you're a slightly different era, Nick. So your lung clinics would have been started off very differently to what they are now. But I agree, those patients that are doing well really keep, the clinic and your day functional. Sam, these patients that are, patients with a history of lung cancer, previous smoking or current smoking, who are now surviving a really long time, and all the survivorship issues of getting older, with smoking-related illnesses potentially or other illnesses, are we the best people to be providing the survivorship care? Who else can do it if not us?
Yeah, I completely agree with you. And actually last week I discharged 2 of my patients who'd been completed their 2 years of Pembro, and it was 5 years later. And it was a social visit, which is beautiful. But equally, then I got to a point of diagnosing a second T1 lung cancer and working that up. And then, there's all these other medical issues that happen because they're 5 years older. And I agree with you that potentially it isn't the best use of a medical oncologist as much as I would, you formed a long-term relationship with these patients to then manage, their comorbidities. And I think we probably need to think about what are the long-term toxicities of the therapies that we've given, because if someone's had an exceptional response to immune treatment, you probably know what their toxicities are if they've become hypoadrenal or their thyroid's become underactive. They're managed. So what are these things that we're watching for 5 years later? I'm not sure. So what are we doing in this survivorship clinic other than saying, isn't medical oncology wonderful and we've cured some advanced cancers?
I think that it's not a problem. The problem of how we look after our survivors it's a nice problem to be discussing, I think, oncology podcast. We've touched on this throughout, I think, but in terms of opportunities for how TOGA and other groups could potentially help collect some of the data we need to work out what to do, both in the, who are the patients that are benefiting from this therapy with a new indication, what the potential problems that we might be causing, and how we react to that, and also the survivorship problem in inverted commas of, what's the best way, what are the potential strategies. A survivorship clinic is a lovely resource to have access to, but clearly does not exist throughout the country. But what do you think, what could we do as a group that potentially would help us with all of those problems? Nick, as former chair, start with you.
Yeah, good point. So I think first things first, look at some of the data collection opportunities. Let's collate our data to see what's happening. When it comes to survivorship, problem we have is resourcing, and it's a partnership. When we see a patient as an oncologist, I look at myself as a physician, having been on the college physician exam for the last 20 years as well. We also have a duty to look at the patient as a whole, not just focus on our little bit. And I guess this concept of survivorship says, hold on, you've got to start looking at all these things. But immunotherapy taught us about that early on, because we get all the endocrinopathies and other things. And then you got bone health considerations in women with breast cancer and other things. So as an oncologist, we can't just say we're just treating the cancer. We're actually meant to be treating the patient as a whole. And so it's a partnership with the GP, and I guess understanding who else is involved in the patient's care. So what I've tended to do, if you've got a patient who's got a very strong relationship with the GP, who's well looked after in terms of their comprehensive health, takes the pressure off for me to take on some added roles and focus more on the cancer. And then I've had situations where we've become the default because the patient isn't connected with the GP. And so I've tended to have that pragmatic view and then try to put the patient in an environment or follow-up where they will. But we probably, your point was about what do we do as a group. I think collecting data is important. This is an opportunity, having Ipi Nivo available to us. We could set up a national observational study where we collect minimum data sets, really simple things like outcomes, response to rechallenges, things that were brought up in conversation tonight, and then look back at our experience, compare it to what is in the literature, and see what learnings there are. Integrate things as they're available. For example, if there's ctDNA access, we can start integrating that. And again, collect some data prospectively as opposed to trying to look back all the time.
So Lavinia, you did your, I guess, research/PhD more recently than some of the others. And what are your thoughts about, I guess, the open questions that potentially TOGA and other groups could work on with this therapy as an option?
I think some of the things that a trial, I guess, cannot capture. Trials did not capture patients who have poorer ECOG, so maybe the patients who, in the real world, not everyone is ECOG 0 to 1, and now we're going to start treating patients. I'm sure the discussion, there will be potential where you will discuss this regimen with someone who's potentially ECOG 2, and I guess, tox in those patient population as well, and, quality of life in terms of, their tox. And so I think the real world data is important here, definitely. Whether or not, I think, I was just talking about ctDNA because that's what I did my PhD in, but, we don't use ctDNA, obviously, in the non-oncogene driven non-small cell lung cancer, especially as what Nick alluded to. But, there is potential where, we could look at whether we need to de-escalate treatment, which is what a lot of, tumor types are looking at as well. I think that's the one thing that we could do, and then re-escalating. So that's one area where, the biomarkers, I think, to guide us.
Thanks to Nick, Sam, and Lavinia for joining us tonight. Thanks again to Bristol Myers Squibb for sponsoring. If you haven't listened to the first episode in this series, do go back and catch up with that. As always, thank you for listening to TOGA's Conversations in Lung Cancer Research. And if you enjoy the show, please do rate and review wherever you listen to your podcasts.